Number 8, shoulder case study. As you read through the case study, you'll see a volleyball player, 16 years old. The pain is 4 to 10. The key to this one is started volleyball practice about 2 weeks ago. Intermittent shoulder ache, worsened over the last 3 days with increased serving. Go through the components of it. As you work your way down, you'll see that it's aggravated by serving a volleyball, eased with meds and rest. You'll see the DAS score of 25. So you want to remind your therapist that the lower the score, the better. So 0 equals least disability, 100% equals most disability. So when you look at that, when you look at thoughts following the exam, the severity, we could probably say it's minimal to moderate. It affects his activity. The pain level is somewhere in the middle, 4 out of 10, 4 to 5. So it's somewhere in that middle of severity. Irritability, it's moderate. He can still play, so it's not minimal, but it's not where he can't play. So it's in that middle again. The nature, we're thinking, is it possibly the possibilities are an impingement, so some type of subacromial type of pathologies, or bursa, tendon, or capsular ligamentous instability. The stage is more of an acute stage and going towards subacute. And we looked through red flags. We didn't see any. There were no specific red flags in this patient. As we go through it, look at increased kyphosis. You're going to have your student perform each part of the exam. We have them do a clearing exam, which for this patient was clear. Go through your active range of motion. And in this part, the patient had flexion, abduction to 170, excessive scapulothoracic mobility, and it caused the pain in end ranges. Active external rotation at 20 degrees is 60. At pain at mid-range, end range, at external rotation at 90 was 100 degrees. So he was having pains at the extremes. Internal rotation was limited. Go through passive again, practice it. Go through flexion. You can also have them practice how to do glenohumeral abduction without external rotation, pure glenohumeral, or glenohumeral abduction with external rotation. Look at that. Passive accessory, we could do it in positions we talked about in last time. This person is hypermobile AP. Pain and resistance occur simultaneously, meaning it's more subacute. PA, pain reported before resistance, so there's some type of acuteness in that posterior to anterior capsule. Practice your AC joint palpation. And if we went into your muscle testing, the key is to practice these things. So if we had external rotation, he got 3+ out of 5. Pain eased with rest. 3+, the cuff is 3+, the lower trap is 3-, all the scapular muscles. So practice those testing. The key to this part is we go through your exam. A full can, empty can, impingement are all negative. Apprehension, relocation, surprise are all positive. And load shift is positive. Change that. As we work through it, the interesting part is to look at, remember the clusters from last time. There's a big positive likelihood ratio of the patient having some type of instability based on the testing. If we went from the tests before, there's a positive likelihood ratio of almost 40, which is huge. So when these tests together, likelihood of this person having anterior shoulder instability is high. And there's probably not any impingement, even though that was one of our hypotheses. There was no positive test for any kind of impingement testing. Just more of a laxity for this patient. Suggestions, again, for this person, for this treatment, you're going to suggest maybe they do some rest initially, decrease the volume, the load, meds as needed, range of motion, rotator cuff, scapula, and proprioceptive. Remember, we want to go through it, the idea of mobility trumps stability. Make sure they have good mobility. Discuss the importance of volume, how much increased volume the patient had because of the increased activity with volleyball. Scapular fatigues with weakness as you continue to use it. And now we're going to go into your lab part. You're going to go through, again, mobility. You can practice some mobility type drills for neural. You can have them do glides, even though it's not for this patient. Joint mobility as needed, maybe some cervical thoracic mobility, areas around it. Some soft tissue techniques maybe for subscap, lat, teres, and go by your strengthening. Remind them that lying down to quadruped to sitting, progression of forces, progression of position by surface, planes, upper body, again bilateral, unilateral is last, alternating's in the middle. So that's the key for during this component of it. Talk through, practice some case studies, let them get used to practice a lot of hands-on skills.